Welcome to this training video on awake fiberoptic intubation, an essential skill for managing the anticipated difficult airway. This module is designed to improve confidence, understanding, and performance among anesthesiology residents. When we talk about a difficult airway, we're talking about in any situation where mask ventilation, supraglottic airway ventilation, or tracheal intubation may be difficult, alone or in combination. Facial and anatomic features can give early warning. Some examples of anatomic features that may suggest a patient will be a difficult intubation include long upper incisors, a prominent overbite, poor voluntary prognathy, less than 3 cm inter-incisor distance, Melanpodi class 3 or 4 airway, a highly arched or very narrow palate, a stiff or indurated mandibular space, a thyromental distance of less than 3 finger breadths, a short neck or a thick neck defined as greater than 17 inches, or a patient with limited flexion or extension of the neck. The ASA difficult airway algorithm emphasizes planning before induction. When you anticipate difficulty with laryngoscopy, ventilation, or both, the algorithm specifically recommends considering awake intubation. Under the awake pathway, you can choose awake non-invasive techniques like awake fiber optic or awake video laryngoscopy, or awake invasive techniques such as tracheostomy or cricothyrotomy, depending on the situation. You may also choose an alternative anesthetic or postpone the case if risks are unacceptable. Based on the ASA difficult airway algorithm, consider an awake fiber optic intubation when you identify any of the following. 1. Suspected difficult laryngoscopy. 2. Suspected difficult ventilation with mask or supraglottic airway. 3. Significantly increased risk of aspiration. 4. Increased risk of rapid desaturation. Or 5. Suspected difficult emergency invasive airway. All of these may include patients with distorted anatomy from tumors, prior radiation, infection, or trauma. When any of these criteria are present, awake fiber optic intubation allows you to maintain spontaneous ventilation, airway reflexes, and secure the airway before induction. For awake intubation, remember 3 general principles. Intubating conditions should be dry, still, and bloodless. The patient should remain spontaneously breathing to preserve oxygenation and ventilation. The patient should be following commands and cooperative. To achieve this, we can combine amnesia, so the patient has limited recall of the procedure, analgesia and topicalization to blunt the gag, cough, and pain, anxiolysis and antisalagogue to reduce anxiety and secretions, and finally vasoconstriction for when using the nasal route to limit bleeding and improve visibility. Awake intubation is much easier when you understand airway innervation. There are 3 key sensory nerves we target. First, the glossopharyngeal nerve, cranial nerve 9, innervates the posterior third of the tongue, tonsillar pillars, and oropharynx. This is responsible for the gag reflex. Number 2, the superior laryngeal nerve, branch of cranial nerve 10 or the vagus nerve. Particularly, the internal branch provides sensation from the epiglottis down to the vocal cords. And third, the recurrent laryngeal nerve, branch of cranial nerve 10, the vagus nerve, provides sensation below the vocal cords and motor to most intrinsic laryngeal muscles. Topicalization or blocks of these nerves can markedly improve patient comfort and conditions. Options to anesthetize the airway include targeted nerve blocks. The superior laryngeal nerve can be blocked by injecting local at the hyoid bone. The glossopharyngeal nerve can be blocked by injecting local at the base of the tonsillar pillar. Using a transtracheal technique, you can block the recurrent laryngeal nerve by injecting local through the cricothyroid membrane. Using a spray-as-you-go technique through the fiber optic scope, you can also reach the superior and recurrent laryngeal nerves. Additional airway analgesia options include topical methods such as a nebulized lidocaine, atomized sprays, anesthetic gels, and hurricane spray, which uses 20% benzocaine. In this protocol, we primarily emphasize topicalization with 2% lidocaine using an atomizer and spray as you go, reserving nerve blocks for operators with appropriate expertise. Although some may prefer nebulizers over atomizers, as mentioned, our protocol favors an atomizer. Nebulizers are generally easier to administer, better tolerated, and can be started pre-op, but they often take longer and may require a higher total lidocaine dose. Atomizers, on the other hand, work faster, use less lidocaine, and provide better mucosal adherence with fewer coughs. leading to improved comfort during the procedure. Though they're less comfortable up front and require a more active technique from the provider, in practice, the choice depends on patient tolerance, time, and operator experience. Evidence comparing 2% and 4% lidocaine for the spray-as-you-go topicalization shows similar intubating conditions, but lower total dose and lower plasma concentrations when using 2% lidocaine over the 4% lidocaine. For that reason, this protocol favors 2% lidocaine to provide effective anesthesia while minimizing systemic exposures. First, as we get started, an antisalgague is essential. We use glycopyrrolate 0.2 to 0.8 milligrams IV titrated to effect. Drying secretions improves visualization and enhances the effectiveness of topical local anesthetic. An added benefit is that the slight heart rate increase can help offset bradycardia from dexmedetomidine. This step is highly important and best is started early in pre-op to allow the medication time to work. Next, we select sedation that keeps the patient calm but still breathing and cooperative. Medications like propofol, midazolam, fentanyl, and ketamine are familiar and widely used, but the literature associates them with less ideal intubating conditions and more frequent adverse events when used as primary agents for awake intubation. High-quality evidence strongly supports dexmedetomidine and remifentanil for awake fiberoptic intubation. Together, they provide cooperative sedation, excellent conditions for airway instrumentation, and minimal respiratory depression. For dexmedetomidine, our protocol uses a bolus of 1 microgram per kilogram over 10 minutes. This is the most critical component and should be started early, ideally as soon as the patient enters the operating room. This can be followed by an optional infusion of 0.4 micrograms per kilogram per hour during the procedure, but titrated to effect. This produces calm, cooperative sedation with preserved respirations and allows the patient to follow commands. For remifentanil, we use a continuous infusion of 0.05 micrograms per kilogram per minute based on ideal body weight. We avoid bolus dosing to reduce the risk of apnea and chest wall rigidity. Remifentanil is titrated to suppress cough and discomfort while maintaining spontaneous ventilation. Naloxone should be readily available for rescue. Before bringing the patient to the room, ensure that all equipment is present and functioning. An atomizer ready with 10 milliliters of 2% lidocaine drawn up with additional basic equipment such as nasal cannula, mask, nasopharyngeal airways, gauze, and tongue blade. Ovasapien are optional equipment that some may find helpful as well. As a side note, let's compare a standard endotracheal tube to a Parker FlexTip endotracheal tube. With a standard endotracheal tube, the left-facing bevel tends to direct the tube to the right, where it often catches in the right arytenoid. The Parker endotracheal tube addresses this by using a symmetric, flexible tip that tracks more smoothly over the fiber optic scope. This reduces the gap between the scope and the tube, leading to a smoother advancement, fewer repositioning maneuvers, and fewer repeated attempts. Additionally, when gathering your supplies, please note that the epidural catheters are located in the APS cart near the regional office. In the drawers, you'll find a 20-gauge epidural catheter. This size only works with our red ambuscopes. Now for the rest of our equipment. Your fiber optic bronchoscope and tower should be defogged and tested. Options include either a stored scope or an ambuscope with tower. We use the red ambuscope for our demonstration since the size works best with our available epidural catheters. A 20-gauge epidural catheter should be threaded through the suction channel for the spray-as-you-go technique. After threading the catheter, attach an alligator clip to the end closer to the suction channel opening. Then attach a 3 ml syringe with lidocaine to the clip. When testing the catheter, you should see droplets coming out of the distal tip. Then preload your 7/0 endotracheal tube, if available use a Parker endotracheal tube, to the end of the scope. Having everything ready and organized dramatically improves efficiency and success. Using the UNC Resident Awake Fiber Optic Intubation Teaching Guidance, we'll walk through a standardized time-based protocol. Before you begin, alert the anesthesia technician that an awake fiber optic intubation is planned. Position patient sitting upright with head of the bed up. Ensure standard monitors and nasal cannula are applied. Although some providers may choose supine, for an awake fiber optic intubation, we generally prefer the patient sitting upright. The upright position improves airway clearance through gravity, increases functional residual capacity for better oxygenation, and often improves patient comfort and cooperation. These advantages can make the procedure smoother and safer, especially in patients with limited respiratory reserve. At approximately 12 minutes before intubation, begin the dexmedetomidine bolus, 1 microgram per kilogram over 10 minutes. Starting early allows the infusion to complete before you insert the scope, giving time for sedation to reach a steady state. At 10 minutes before intubation, apply 2% lidocaine via the atomizer to the tonsils or pillars to topicalize the glossopharyngeal nerve, as well as the hypopharynx to topicalize some of the area covered by the superior laryngeal nerve. In total, use 3 to 5 milliliters per side. Use a tongue blade or laryngoscope blade for visualization, and carefully track the total lidocaine dose. At 5 minutes before intubation, repeat the 2% lidocaine atomizer application, again delivering 3 to 5 milliliters per side. This reinforces oropharyngeal anesthesia and helps suppress the gag reflex. At 2 minutes before intubation, you may start the remifentanil infusion at 0.05 micrograms per kilogram per minute if additional cough suppression and comfort are needed. Dexmedetomidine alone may be sufficient for some patients. Titrate the remifentanil carefully to avoid oversedation. At time 0, ask the patient to open their mouth and protrude their tongue. Stabilize the tongue with gauze. Assess the gag reflex. If it is still strong despite topicalization, consider additional local anesthetic. Position yourself at the head of the bed on either the right or left side of the patient. Stand slightly to the side of the patient's mouth so you can maintain a neutral wrist position and direct line of sight to both the patient and the video screen. Advance the fiberoptic scope midline along the sulcus of the tongue, always moving into a visible lumen. The patient should remain responsive to simple commands, such as take a big deep breath. Let inspiration pull the scope in, advancing with inhalation, and pausing during exhalation. When the vocal cords are seen, advance the epidural catheter through the scope and inject 2 to 5 milliliters of 2% lidocaine. The spray-as-you-go technique, to anesthetize the cords and subglottic region. After coughing subsides, advance into the trachea until the tracheal rings and carina are clearly visualized. Then, railroad the endotracheal tube over the scope. Again, timing advancement with an inspiratory breath. Confirm tube position by visualizing rings around the tube tip. Then remove the scope while stabilizing the endotracheal tube. Once the airway is secured, reassure the patient, confirm end-tidal CO2, and proceed with induction, often using a reduced dose of propofol, given the ongoing dexmedetomidine and remifentanil. After turning the patient supine, secure the tube and ensure hemodynamic stability. After the case, document awake fiberoptic intubation as a notable event in the electronic record, including any challenges encountered and the strategies used. This supports quality improvement and future airway planning for the patient. Awake fiberoptic intubation is one of the most important skills in difficult airway management. By recognizing when awake intubation is indicated, understanding the airway anatomy and innervation, applying evidence-based topicalization and sedation strategies, and following a standardized protocol, residents can significantly improve both safety and success. Mastery of this technique will not only help you care for your complex patients, but will also prepare you for ABA OSCE and oral board scenarios. Thank you for participating in this training module.